This session is brought to you in collaboration with Assist International, Stanford Medicine Division of Global Anesthesia,
Fourni
University
grâce
of
au
New Mexico,
partenariat entre
University
Assist
Health System,
International,
Abuja
Stanford,
Teaching Hospital, and the Learning Resources
Aminu
Center
Kano Technical
of
Hospital,
Global Anesthesia and Critical Care.
LRC.
So, a few housekeeping items before we begin. We will be using the chat function for question and answers.
La fonction du chat sera utilisée pour
Please type your questions
les
in the chat box and
questions-réponses.
feel free to introduce yourself. If you have any issues and you
Vous
need
pouvez vous
assistance,
présenter en utilisant le
please
chat
reach through the
et
chat.
poser vos
Also
questions.
remember that our session
Si
is
vous avez des
being
soucis
recorded.
techniques, vous pouvez également utiliser le chat.
To be recorded.
Cette session est enregistrée et le fait d'y participer signifie que
As I
vous pouvez
mentioned, this is our
l'autoriser
session on
automatiquement.
therapy
Vous êtes d'accord pour
and
l'enregistrement.
and we will be discussing on the final frequently answered questions and resources for oxygen and critical care.
Nous discutons aujourd'hui des
Today,
questions,
we're going to
des
have
FAQ, des questions fréquemment posées
Ahmed from Aminukai
autour
Teaching Hospital in
de
New York.
l'oxygénothérapie et des soins
Also, we
intensifs.
are going to have Dr. Hassan Maina from the
Nous aurons
Stanford
Dr.
University
Datti,
of Yola,
Dr. Irène,
Irene Irinose Akide,
Dr. Salim et Dr. Hassan
Specialist Teaching Hospital Irua in Edo State, Nigeria.
comme copanélistes.
Dr. Salim Ibrahim Abdullahi from Abubakar Tafawa Balewa University Teaching Hospital, Bauchi, Nigeria. Also remember that for those of you who would like French interpretation, there is an icon for interpretation at the bottom of your screen.
Il existe pour cette session d'interprétation française.
Version of Zoom for it to work, and you can click and then you can choose on French and you can have the interpretation.
Il suffit de
Brief introduction.
cliquer sur le bouton de traduction et vous pouvez choisir la langue que vous souhaitez.
Dr. Datti, welcome.
Bienvenue, Dr. Datti.
Thank you very much, Kevin.
Merci, Kevin.
Good afternoon, good evening, wherever you are.
Bonjour, bonsoir, que vous soyez. Bienvenue à cette deuxième session. C'est la dernière session pour cette année. Nous nous occuperons aujourd'hui des questions qui reviennent fréquemment tout au long de nos sessions. Donc, autour de l'oxygénothérapie, des soins intensifs, de la COVID-19, de l'obstétrique et de la pédiatrie.
Looking at oxygen therapy. Sorry, before I move on, I think Irene, one of the panelists, have just sent a message she won't be able to join, but I think Hassan and Salim are with us.
Pour information, Irène vient d'envoyer un message pour dire qu'elle ne pourra pas nous rejoindre. Donc,
what are the indications for oxygen therapy?
quelles sont les indications de l'oxygénothérapie et quel est le but de l'oxygénothérapie?
Remember well, oxygen therapy basically is
Si vous vous souvenez bien, l'oxygénothérapie permet de traiter l'hypoxémie, le bas niveau d'oxygène dans le sang.
That is anything you give above the 21% that we normally breathe in the mixture of air. So that's oxygen therapy.
Donc, oxygénothérapie, c'est tout ce que vous donnez au-delà des 21% disponibles dans l'air ambiant.
Now, in cellular respiration, in the end, oxygen that is transported to the cell, this is what happens in three main stages. The first stage is aerobic respiration, which is
Respiration aérobique
where glucose
avec la
broken down.
où le glucose est
ATP. The ATP is the energy in bond
transformé en ATP.
used by the body for all our
L'ATP qui est utilisé par le corps pour toutes nos activités.
you will see that it consumes 2 ATP molecules, but then in the end you have 4 molecules produced.
Donc, nous avons deux
The second, this is
molécules
in the
d'ATP
cell.
consommées, 3
The
produits.
second and the third stage they happen inside the mitochondria, and that is where you have acetyl coenzyme A and carbon dioxide produced. And then the carbon dioxide have to be removed.
Donc, c'est là que vous avez le CO2 et l'acétylcoenzyme A produit.
And that is the Krebs cycle.
Donc, c'est
Where more
ça le cycle de Krebs.
are produced. So this is basically, and then you have the stage 4 where you have the electron transfer. Where
Il y a le niveau 4 où l'électron est transféré.
the summary there you have glucose plus oxygen,
Glucose plus oxygène qui donne du dioxyde de carbone, de l'eau
or more ATP
et
energy.
au moins
Where
30
we
molécules
see what
d'ATP.
along the air we exhale. Now, in the absence of oxygen, when there are low
En absence
levels of
d'oxygène
oxygen, the alternate
ou
because the body must produce energy for the activity.
en absence d'oxygène, donc,
Anaerobic without oxygen. So glucose will be broken down through an alternate pathway to produce low ATPs, number of ATPs.
le glucose est transformé en une très faible,
That lactate compound
une faible quantité d'ATP
acidic is injurious to the cell. Now, when there is
avec
acidity,
production d'acide
enzymes
et l'acidité est très toxique pour les cellules.
that speed of all these reactions will be slowed down, and then the person will become sicker and sicker. That is the basis of that. So you can see the reason why oxygen therapy is important.
Donc, vous voyez donc les raisons pour lesquelles l'oxygénothérapie est importante.
Scroll down. So to understand this, you see basically from the cell, you have many cells forming a tissue.
Donc, nous avons des cellules, nous sommes des cellules qui forment des tissus,
From the organ and
l'ensemble des
organ
tissus
to have
qui forment un organe et les organes forment un système.
they work together to make up tissue.
Les cellules travaillent ensemble pour
And these organs then work together for
être des tissus, des organes, le système
what happens in the body.
qui a une fonction. Ça, c'est ce qui se passe dans le corps. Les points clés ici, c'est que l'oxygénothérapie d'oxygène est un traitement pour l'hypoxémie, mais pas un traitement pour l'essoufflement. Il n'a pas été prouvé que l'oxygène ait un effet constant sur la situation d'essoufflement chez les patients non hypoxémiques.
And then you will normalize the situation. So if Salim is available, I don't
Si
know.
Salim est disponible, docteur Salim.
Yes, I'm okay, sir.
Okay. If you can kindly take us through the next two couple of questions with some
Voulez-vous nous faire naviguer à travers ces deux questions?
Question and answers is just to explain these frequently asked questions, which we're just choosing out of the many questions that were sent in. Thank you.
Okay. Thank you. And good afternoon, all.
Bonsoir tout le monde.
The next frequently asked question is, what are the optimal targets of oxygen therapy?
La question, c'est quelles sont les cibles optimales de l'oxygénothérapie et quand l'oxygénothérapie doit être titrée.
Oxygen, like any other, like all drugs, must be prescribed in the right dose. And the right dose is
L'oxygène doit être
the concentration or the flow rate.
prescrit dans des doses les plus justes.
The delivery device, then the FiO2 in case if you are using the Venturi device, and then you prescribe your treatment goal. The treatment goal, because you need to monitor this patient.
Vous devez avoir des objectifs de traitement avec un suivi.
So you have to prescribe your target SpO2 because
Vous devrez avoir un objectif de SpO2.
Depending on the SpO2 goal, and then you prescribe monitoring, like you say, which is the SpO2.
Donc, en fonction de votre objectif, à travers cet algorithme, vous allez utiliser un matériel, le matériel le plus adapté et mettre en place un suivi.
hear you, Dr. Salim.
Nous ne vous entendons plus, Dr. Salim.
Yes, I can hear him here also. Okay, so let me continue before he comes back. So, like what Salim was saying, that in giving oxygen therapy, you have a guideline when you want to escalate the treatment. And with the oxygen therapy devices that you
Nous
have,
avons une note directrice, un guide,
nasal cannula, you
donc
have,
avec des canules nasales,
simple face mask, you have the venturi, and
un
you
masque
have
facial,
non-rebreathing face mask. Now, like he was
des
saying,
masques faciales simples ou des masques
your
faciales
target,
sans inhalation avec
you want to achieve. Maybe a patient
un réservoir. Donc, en fonction des
target
objectifs,
is 88% and your target is 95%. But you need to monitor.
en fonction de vos objectifs,
You use your pulse oximeter.
vous avez besoin de faire un suivi avec l'esprit clinique et votre oxymètre de pouls.
Because we know it's 1 to 5 liters per minute. That's the
Donc,
range
1 à 5 litres par minute
cannula, and you're getting
pour le canule nasal
that will give you oxygen percent. I mean the
chez
concentration
l'adulte
of oxygen
et chez les enfants en âge d'école.
to 40%. So if you're not achieving your target, then you need to move on to the next device, which is
Donc,
simple face mask.
si votre objectif n'est pas atteint, vous devez passer à l'autre outil
You're not getting
qui est le masque facial.
the target, then you move on to the next device that you
Et
have.
lorsque là encore, vous n'avez pas l'objectif qui est atteint, vous passez à l'autre
Also take note of the device you have
matériel.
in your facility, because if you
Mais vous
have,
devez prendre en compte ce que vous avez de disponible dans votre
have
hôpital.
a non-rebreather mask, you have to give it at minimum of 10 liters per minute, but you don't have oxygen available, then that could be a problem. Okay, so this is just to guide you on how best to administer oxygen, taking note of your
Donc ça, c'est juste pour vous guider dans comment
reserve. Like
de
I
façon
said,
optimale utiliser
electricity,
l'oxythérapie.
it's good to use your oxygen concentrator and conserve your cylinder oxygen so that when you don't have electricity, and then you can use the cylinder oxygen.
Donc lorsque vous n'avez pas d'électricité, par exemple, vous pouvez utiliser votre bonbonne cylindre d'oxygène.
I can hear you. Sorry, I'm having network issues.
Yeah, so I try to just continue with that up to how to navigate or to use the algorithm here on escalation. So you may continue, please.
Okay, so like I was saying that the two reasons why you can titrate up oxygen therapy is either the patient is deteriorating on the already prescribed oxygen therapy, or you are not achieving the goal. So if you are not achieving the goal, or
Est-ce
the
que
patient is deteriorating, there is need to escalate
vous n'avez
the
pas
therapy.
d'objectif
The
que le
therapy itself
patient
can
présente des complications, vous pouvez avoir à passer à une autre,
do that with the change of delivery device.
au prochain
It is always advisable to start
appareil
with the
d'oxygénothérapie.
and that can be achieved with the nasal prongs. So, and which the flow rate for the nasal prongs is 1 to 5 liters per minute. So, if
Le
you
masque
start
nasal,
and you
c'est
are not achieving the goal, then there is a need to increase the flow rate. The
la,
moment you
la canule, c'est 1 à 5 litres par minute. Le masque simple, c'est 5 à 10 litres par minute
so you can move to
d'oxygène.
simple face mask or the venturi device, depending on what is available, because the best delivery device is always
Donc,
what is available. So what is
le meilleur dispositif de fourniture d'oxygène, c'est celui qui est disponible.
for the
Donc,
patient.
vous devez prendre cela en compte dans votre
Please scroll
prise en
down.
charge.
Okay, let's scroll down. So the second question is, sorry, we have answered that. When should oxygen therapy be titrated up? Okay, so before is a resource material that carries explanation of what we just highlighted.
Donc,
Okay.
ce que vous voyez là n'est que des explications de ce que nous avons déjà discuté tout à l'heure.
Okay, so the next question, what are the preferred devices in
La question qui suit, c'est quels sont les appareils les plus appropriés pour administrer l'oxygène. Donc, comme je l'ai dit tout à l'heure, le meilleur appareil, le meilleur dispositif est celui qui est disponible. Donc, passant par la canule nasale, les masques faciales, jusqu'à la ventilation non invasive. Mais dans tous les cas, c'est ce qui est disponible qui est le meilleur pour vous.
What determines the duration of time oxygen
Qu'est-ce
therapy
qui détermine la durée de l'oxygène thérapie?
So there is actually no limit to the duration of oxygen therapy.
Il n'y a pas de limite pour la durée de l'oxygénothérapie. Mais le sevrage peut être fait lorsque vous avez atteint l'objectif, lorsque le patient est capable de maintenir une saturation à plus de 90% à l'air ambiant. Quelles sont les différentes méthodes d'oxygénothérapie? Donc, la classification en invasif et en non invasif. Non invasif, nasal canule nasale, masque facial sont des méthodes non invasives. Les méthodes invasives, donc la ventilation mécanique. L'autre classification, c'est flux lent et flux rapide. La canule et le masque sont classés dans le flux lent. Parce que la quantité n'est pas importante. Le flux élevé donc, le flux élevé, c'est lorsque vous utilisez un flux qui est supérieur au flux naturel, flux normal que le patient utilise pour l'oxygène. L'oxygénothérapie traite l'hypoxémie et n'est pas assistée par la ventilation. Donc, la ventilation permet de la ventilation permet de faire sortir les déchets, donc le CO2, et donc ne permet pas de traiter l'hypoxémie. Et donc, n'assiste pas à l'oxygénothérapie. Les méthodes de l'oxygénothérapie peuvent être considérées de plusieurs manières. Les sources d'oxygène sont les cylindres concentrateurs d'oxygène, les bonbonnes d'oxygène. La fourniture d'oxygène peut être invasive ou non invasive. Et le flux, on peut avoir un flux faible ou un flux élevé. Les patients doivent être suivis de façon continue pour déterminer si leur besoin d'oxygène et leur besoin d'aide à la respiration sont satisfaits. L'oxymètre
medical science.
de pouls doit être
Medical science, like
disponible
especially cyanosis,
et
you
utilisé chez les
put
patients.
them in with cyanosis, and you commence
Et on
oxygen
doit s'aider
therapy.
également des signes
Within no
cliniques
time,
de
the
le patient.
mucosa has turned pink. Then you know that you are winning. But notwithstanding that, the primary cause of that hypoxemia must be seeked for and
Il ne faut
treated.
pas oublier que la cause primaire de l'hypoxémie doit être
We must be available
adressée.
to assess patients receiving oxygen therapy, because it's our guide for titration, either up or down. The best oxygen source and delivery device is the one.
La meilleure source d'oxygène et
So if
de
a
fourniture
patient
d'oxygène
comes
est celle qui est
and these
disponible.
patients require therapy with, say, test mask with non-rebreather, but unfortunately you don't have that, you only have nasal prongs, then it means that nasal prong that you have is the best for that patient, because you cannot say because you don't have the non-rebreather test mask, you cannot administer oxygen.
Donc,
You have
le
to
meilleur,
administer oxygen.
la meilleure source et le meilleur équipement pour délivrer l'oxygène est celui qui est disponible. Donc, quel que soit celui que vous avez,
Yeah, thank you very much.
vous pouvez l'adapter, l'utiliser chez votre patient.
The fifth point here is very important. The best oxygen source
Donc, ce dernier point est très important.
that is available to you. And I want to add that in some
Je voudrais-
very poor resource settings, unfortunately, there will be no pulse oximeter. So you, like he said, you have to rely on the clinical.
Dans certains de nos centres, il n'y a pas d'oxymètre de pouls. Et dans ces cas, il va falloir se fier aux signes cliniques et les exploiter pour monitorer le patient.
Ali Maina, I don't know if you are around.
Docteur Hassan,
Okay, please, you're welcome. So take some of these questions and give us an insight for the benefits of our participants.
veuillez nous faire naviguer les prochaines questions.
So,
Les
good
quelques-
evening all. The next question says, what are the complications with oxygen
La
poisoning
question qui suit, c'est quelles sont les complications de l'oxygénothérapie,
and prolonged use?
l'empoisonnement
From the previous discussions, we
à
know
l'oxygène,
that oxygen
donc
also
l'extrait
has
d'administration et
and side
l'utilisation
effects.
prolongée.
We try to bring down oxygen or stop oxygen when oxygen is no longer required. That is why, like the previous speaker said, we have to be monitoring the oxygen as we are giving the oxygen.
Donc,
so
il est
that
important de faire le suivi, le monitoring de l'oxygénothérapie parce que parfois, lorsque
oxygen therapy.
nous administrons plus d'oxygène que nécessaire, nous pouvons avoir des complications.
And it is displayed in the diagram below. Can we go
Le diagramme
little?
que vous voyez permet
Hyperoxia is a term used for
d'avoir une vue
excessive oxygen
synoptique.
in the tissues.
Donc, l'hyperoxyge, c'est
This is a schematic diagram
l'augmentation du taux d'oxygène dans les tissus.
possible complications that can occur with prolonged oxygen use. I think you've gone lower. It's above, yes. Okay. So from the 12 o'clock position, you can see there is in COPD patients. We all know that COPD patients, that's a chronic obstructive pulmonary disease.
Donc, nous avons des patients qui sont obèses, des caractéristiques chroniques, bronchopneumopathie chronique obstructive.
Carbon dioxide tension, so they use oxygen to stimulate respiration. So when you give excessive oxygen, that
Donc, l'excès d'oxygène chez les patients
drives respiration will also go away, and you have more respiratory distress than when not given.
entraîne une augmentation de la détresse respiratoire.
Just right to that induced hypercapnia, we can see
Avec une hypercapnie.
proliferative retinopathy, and this happens usually
Il vient avoir tous les enfants prématurés.
but it also can happen in normal neonates, newborns. When you give excessive oxygen, the vessels are not fully developed, and there can be injury.
Les vaisseaux ne se développent pas bien chez ces enfants lorsqu'ils ont trop d'oxygène.
So it is called retinopathy of prematurity. We go
Donc, cela s'appelle la rétinopathie des prématurés.
brain, and excessive oxygen also causes cerebral toxicity, and there
Donc,
is
l'excès d'oxygène peut entraîner une toxicité cérébrale
complications and
avec des complications cérébrales.
in the brain functions. Yes, we have reactive oxygen species that are formed, like
Donc, les
the
espèces réactives de l'oxygène peuvent être formées.
examples here in the middle in this small
Donc, je
box.
vous envoie les exemples là.
Yes, so we have the superoxide, we have the hydrogen peroxide, and,
Donc,
and the rest.
le, l'anion superoxyde, etc. Donc, ces espèces réactives de l'oxygène sont toxiques
Where we have cellular injuries.
avec des dommages au niveau cellulaire, avec apoptose, autophagie, inflammation.
This is how it escalates to form tissue injury and then systemic inflammation.
Ce qui peut entraîner
On
une
the
inflammation
left
systémique.
side, the lower left side, we have vasoconstriction. When you have excessive oxygen in the blood and in
Taux
the
d'oxygène dans
vessels,
le sang, dans les artères, dans les artérioles, peut entraîner une vasoconstriction.
so you have excessive vascular constriction, and then you have constriction in the coronary arteries, that is in the heart. You have it in the cerebral arteries, which can also explain some of the problems that we have with those organ systems. Even in the arterioles of many tissues that are not these major organs, we can have all this vasoconstriction causing major disadvantages and problems in the organ systems. Can we go down? Okay, we have, yes, we have, okay, let's go on, let's go. The last one there is
Le
pulmonary
dernier
toxicity,
point est
which is
la toxicité pulmonaire
effect of oxygen
qui est
toxicity
directe,
to the lungs.
qui est une toxicité
There
directe
can be denitrogenation, atelectasis. We all know
avec
that
dénitrogénation et atélectasie.
alveoli is very important in keeping the alveoli open. So when we give too much oxygen, it pushes the nitrogen out of the alveoli and causes atelectasis in the lung, in the alveoli. So can we go down? Okay, so these are some key points.
Donc voilà, c'est un point clé.
Already mentioned that oxygen therapy can lead to retinopathy.
L'oxygénothérapie peut entraîner une rétinopathie des prématurés chez les nouveau-nés. L'hyperoxie peut entraîner un stress oxydatif dans le corps.
The oxidative superoxide ions and all those other ions. Monitor SpO2 frequently to adjust the flow.
Il est important de monitorer la SpO2 de façon fréquente pour ajuster le flux d'oxygène.
We have to be monitoring the SpO2 to prevent these complications. Immediately we see that the need for oxygen is no more there. We win.
Lorsque le besoin d'oxygène n'est plus là, il faut sevrer le patient.
100% SpO2.
Donc, nous ne devrons pas
Target 100%.
avoir une SpO2 de 100%. Comme vous l'avez vu, l'unité d'oxygène n'est pas sans conséquence. Donc, il faut sevrer dès que possible et avoir comme objectif de baisser la FiO2 à moins de 0,6. Donc, le ramener la FiO2 à une valeur très faible, à moins de 0,6. Vrai ou faux, l'oxygène fourni par le masque avec un réservoir de 15 litres par minute est considéré comme l'oxygénothérapie à flux élevé. Donc, cette vidéo nous permet d'avoir une réponse à cette question.
High flow therapy. High flow therapy is when oxygen is being delivered to the patient at a flow rate that meets or exceeds their inspiratory flow demand. What does that mean? Well, did you know that at rest, the average adult will inhale at a speed of 20 to 30 liters per minute? In other words,
Au
if
repos,
someone
l'adulte
was standing next to
utilise
you
20 à
and
30
with a
litres par
radar
minute
gun
d'oxygène.
pointing at your nose, capable of measuring how fast you're inhaling while you're relaxed, the speed at which you inhale would be at around 20 to 30 liters per minute. So high flow therapy should be capable of matching the inspiratory flow or even exceeding it.
Donc,
If an
le
oxygen
flux
device
élevé
delivers
devrait permettre tout au moins
inspiratory flow,
d'atteindre
then the delivery is called low flow. So because the average
Cette
adult who is
vitesse
at rest inhales at a speed or flow of 20 to 30 liters per minute, a
de
high
20 à
flow
30
device
litres par
should
minute.
be capable of delivering at least that much. Now, in order for this high flow of oxygen to be comfortable to the patient, the oxygen should be heated and humidified to
Donc, pour
maximize
être confortable,
and comfort.
l'oxygène
Sometimes you'll
à
see
haut débit doit
literature
être
describe it as
réchauffé et
heated
humide,
and humidified high
humidité.
flow oxygen therapy, or heated and humidified high flow nasal cannula, or to keep it short, it may be referred to as HHFNC or HFNC or even HFOT or HFT or some other variation of that. More recently, Vapotherm has chosen to refer to their heated high flow therapy as HVNI. They've even tried to describe HVNI as mask-free NIV, but don't get thrown off. On the FDA's website, it clearly identifies their device type as high-flow humidified oxygen delivery device. Now, like other high-flow devices, they deliver a high flow of oxygen and it is heated and humidified to help meet patient comfort and tolerance. And some devices, like Vapotherm's Precision Flow, go up to 40 liters per minute. Others, like the F&P Airvo 2, go up to 60 liters of flow, while still others can go even higher. Because at the end of the day, we're just trying to meet the inspiratory flow of a patient, and when that patient is in respiratory distress, that inspiratory demand can be as high as 100 liters per minute. Yikes. So, should high flow therapy
Parfois, on peut
be a
aller jusqu'à 100 litres par minute pour des
form of
patients qui ont
therapy
vraiment besoin
versus
d'oxygène.
non-invasive ventilation? The answer? Absolutely not. High flow oxygen delivers just that, a high flow
La thérapie
but
à haut
sometimes
flux ne
patients
devrait
have
pas
issues with
remplacer la ventilation
CO2
non
or
invasive.
ventilation, and not just issues with O2 or oxygenation. NIV is effective for both oxygenation and ventilation. This is why HFT and NIV are often used together on some patients in a complementary fashion. For
Les
example,
deux ne sont
patients
pas
may be on high
mutuellement
flow therapy
exclusifs
but
et
require
un patient peut
ventilation.
avoir à la fois besoin
Clinicians sometimes
d'oxygénothérapie
escalate to
et de
NIV to
ventilation.
prevent, if possible, intubation and invasive mechanical ventilation. And if a patient is on NIV and can tolerate short breaks, clinicians sometimes switch to high flow therapy to allow the patient to have that temporary break from NIV where they can eat, talk with their relatives, take an oral medication. You get the idea. In fact, in a Vapotherm sponsored study, there were 104 patients who presented to the ER in respiratory distress, and they were initially placed on high flow oxygen. Of those 104 patients, unfortunately, 27 of them failed. And of the 27, 4 were immediately intubated. But the other 23 patients were switched from the high flow oxygen to NIV. And of the 23 patients who failed with high flow oxygen and were switched to NIV, 20 of them improved and did not need further escalation to intubation. In fact, in another study, patients at high risk of post extubation failure were placed in one of two categories. The first category was high flow therapy only, and the other group allowed for both NIV and high flow therapy. Now, the patients that went on both NIV and HFT had a significantly lower rate of reintubation versus the group that went on HFT only. So don't get confused. HFT is definitely not mask-free NIV, but it is a great tool to treat patients with oxygenation issues who are in respiratory distress. So, just a quick final summary on high flow therapy. High flow oxygen therapy usually delivers oxygen at a flow rate equal to or higher than the patient's actual inspiratory flow rate. It should be heated and humidified for patient tolerance, and depending on the flow rate and the seal around the nose and mouth, high flow oxygen may create a CPAP effect, although we don't know exactly how much. It also may wash out some CO2 that is in the upper airway, which is often referred to as CO2 dead space washout, but again, we don't know exactly how much. So that's your quick introduction to high flow therapy.
Okay, we have seen the end of the video, which is very, very rich and very educative.
La vidéo
We
est
have
très
a second
éducative.
video still on high flow oxygen therapy. Let's also play that one.
Nous avons une seconde vidéo que nous allons voir ensemble.
In the previous video, we talked a little bit about what high flow therapy is. In this video, we'll quickly highlight the clinical application of high flow oxygen therapy.
Des
It's important to
indications
notice that high flow
de
therapy is not a replacement for non-invasive ventilation because it
thérapie
is not capable of providing the same level of
à
ventilation
fort
like NIV.
afflux
In high flow therapy, for no inspiratory pressure setting, no PEEP or CPAP setting, no backup respiratory rate setting, no inspiratory time setting, no patient ventilatory alarms. You also cannot monitor the tidal volume, the IE ratio, and there are no loops or waveforms. You get the idea. NIV, on the other hand, can provide all of these. In fact, the only two main controls on high flow therapy are FiO2 and flow.
Donc,
That's it.
les deux paramètres à monitorer sont le flux et le FiO2 dans l'oxygénothérapie à flux élevé.
To maintain an appropriate saturation.
Au début, on
is the
pourrait
flow
avoir
setting.
besoin d'avoir un niveau élevé de FiO2 pour maintenir une, un
This is challenging because it's difficult to
niveau
determine what
approprié de saturation.
respiratory flow is. We learned in the previous video that at rest, when the patient isn't in respiratory
Pour le coup,
distress,
nous avions appris que nous avons 20 à 30
adults
litres par
is
minute
around 20 to 30 liters per minute.
d'oxygène que nous inhalons par
Their flow demand will likely be
repos,
higher.
c'est-à-dire
Clinicians often titrate the flow according to the patient's respiratory rate. In other words, the faster the patient is breathing, the more flow they'll probably need. So if you're using the Vapotherm's precision flow device, the highest flow that you can set is 40
donc,
liters per
plus
minute.
le patient respire rapidement, plus il a besoin d'un flux élevé, plus a un flux élevé
So these two settings, the
d'oxygène.
flow and FiO2, are the two settings available to the clinician to treat the patient in respiratory distress.
En conclusion, le flux et le FiO2 sont les deux paramètres que le clinicien a besoin de monitorer.
You may need to escalate to non-invasive ventilation or even intubation, depending on the severity of the hypercapnia. Likewise, if the pulse ox or the PaO2 on the arterial blood gas cannot be corrected and stabilized despite a relatively high FiO2 setting, then be prepared to escalate to non-invasive ventilation or even intubation, depending on the severity of the respiratory failure and the diagnosis of the patient. But whatever you do, do not delay escalation if the patient does not improve with high flow oxygen. Okay, now remember, because there are no patients,
Ne retardez pas le passage à une étape supérieure lorsque vous avez l'impression que le patient ne réagit pas
one
à
more
votre
control in high flow therapy, and that's the temperature setting. To ensure that the high flow of oxygen is tolerable, heat and humidification should be provided. The exact appropriate temperature
Pour
setting
être sûr que le flux élevé est toléré, la chaleur et l'humidification doivent être fournies en même temps que l'oxygène.
But the key point in temperature setting is to adjust the temperature based on patient comfort and tolerance.
La température doit être ajustée au confort du patient et à sa tolérance.
But we tend to see good outcomes in patients with what we call de novo hypoxemic respiratory failure. De novo hypoxemic respiratory failure is defined as significant hypoxemia, but in the absence of chronic lung disease.
Les patients qui doivent être mis sous oxygénothérapie à flux élevé sont les patients qui ont une détresse respiratoire hypoxémique de nouveau, avec comme critère d'inclusion une hypoxémie significative et comme critère d'exclusion. Les patients qui ont une maladie respiratoire chronique, les patients qui sont en période post-opératoire ou post-extubation, les patients qui ont une
such as NIV. Well,
due à une détresse respiratoire.
Leave your comments below. I would love to read some of your responses. In the previous video.
Okay, thank you very much.
Merci.
So we've listened and viewed the two videos above, which has
vu les deux vidéos.
Explicit explanations on
donne des explications sur l'oxygénothérapie à flux élevé. La question suivante. Quels sont les avantages et les désavantages de l'oxygénothérapie, des appareils d'oxygénothérapie à flux élevé? Donc, dans des points clés, l'adulte normal respire à un flux de 20 à 30 litres par minute. Les patients en détresse respiratoire respirent avec un flux élevé et la thérapie, l'oxygénothérapie à flux élevé requiert des appareils spéciaux pour générer ce flux qui sont plus importants que les flux naturels que le patient a.
also doesn't use the normal cannula
L'oxygénothérapie à flux élevé requiert
cannula and prongs.
des canules nasales
High-flow
spécialisées,
oxygen therapy requires heat and humidification.
de
So,
la chaleur et de l'humidification.
from all this information, we gather that it is more expensive and not readily available in our
Donc,
own.
vous verrez que c'est très cher, ça peut être
These are
très
just,
cher et pas forcément
general,
disponible dans nos...
High-flow oxygen therapy does not assist
Donc, cette oxygénothérapie n'assiste pas
not oxygenation, then
la
high-flow oxygen
ventilation, ne remplace pas la ventilation. Donc, lorsque vous avez besoin de ventilation, il faut plutôt fournir la ventilation. Les deux ne se remplacent pas
Thank you, sir.
mutuellement.
To rest a bit here.
Thank
Thank
you,
you
sir.
very much for your insight. Let me remind our participants whose facility may have isolation centers with now the new wave of COVID-19 and the new variant now. So you find this handy, this high flow oxygen therapy to be of use when you apply in managing COVID-19 patients. So the next two questions, the next question is on critical care, I think. So how is oxygen therapy provided when a patient is in prone position? And then
Les deux prochaines questions.
how is ARDS managed? That is acute respiratory
Comment
distress
est-ce que
syndrome.
l'oxygénothérapie est fournie chez les patients qui sont
Ventilator mode is used for ARDS. So
en
let's scroll down.
incubateur central et comment est-ce que le
There are favorite
respiratoire
sources here
est
for you. When you go through them, you have COVID protocols. You have the
nous avons des ressources là avec
oxygen guidelines
pour les protocoles de COVID, les guides pour l'oxygénothérapie aiguë,
let's scroll down.
les guides pour gérer
And then
les
there's oxygen therapy world chart,
respiratoires.
Thoracic Society guideline for oxygen use, and then you can see you have high flow oxygen therapy part 1 and part 2.
L'oxygénothérapie.
View them or download them for free on this
Toutes les ressources
website.
sont visibles et téléchargeables gratuitement sur ces ressources-là.
So we go to critical care
Nous
proper.
passons maintenant aux soins
Some of the
intensifs.
questions that have been sent, many, so some has been chosen.
Beaucoup de questions ont été envoyées. Nous en avons choisi quelques-unes.
How is critical care provided?
Comment est-ce que les soins intensifs sont fournis en dehors des lits? Comment est-ce que les voies aériennes sont gérées chez les patients? Et la question qui suit est
what do you address? How do you address multiple?
Comment est-ce que vous gérez les urgences multiples? Et comment est-ce que vous monitorez la qualité des soins intensifs? Quels sont les meilleurs indicateurs dans des ressources limitées?
Critical care, we've highlighted a few things there. The critical care
Dans
can be
nos
rendered
sessions précédentes, nous avions dit que les soins intensifs peuvent être fournis partout, que c'est un continuum.
Ill patient that is a patient that needs intervention, immediate intervention to stabilize the patient. So it doesn't have to be in the intensive care unit. And then we talk about rapid response team.
Les soins intensifs uniquement. Nous avons parlé des équipes de réponse rapide qui vont se baser sur certains protocoles avec des signes d'alerte. Les signes d'alerte, ce protocole peut être facilement développé dans vos
signs that we frequently take on the ward. So it's just to recognize that if the patient is tachypnic or there is tachycardia or there is
reconnaître que le patient est tachypnéique, tachycardique, etc. pour savoir quand intervenir. Donc, c'est un continuum de soins en dehors de l'hôpital, dans les soins intensifs, etc.
emergency, emergency where, for example, a patient that is involved in a road traffic accident and has suspected blunt abdominal injury, maybe a
Un
splenic.
patient qui a une hémorragie interne abdominale après un accident de la circulation,
The blood pressure will be low,
sa pression artérielle va diminuer
probably with imminent shock. So you need to administer fluids
avec un choc
to restore
hypovolémique. Donc là, il va falloir mettre
and then also you need to administer
un
oxygen
remplissage
to stabilize the patient.
vasculaire
And
pour
then, of course,
stabiliser.
that kind of patient, the patient will need laparotomy and probably splenectomy to restore
Ce patient aura besoin probablement de l'apparatomie de splenectomie.
homeostasis. So this is one typical example. So you need to understand the rapid response team, the
Vous avez besoin
components,
de comprendre les équipes de réponse rapide, les protocoles, les signes d'alerte.
protocol. You don't have to have the same protocol across all facilities, but
Vous n'avez pas à avoir le même protocole à travers tous les hôpitaux.
Equipment to supplement, then you incorporate into your protocol. This is how you can address these questions.
Voilà comment vous pouvez gérer cette question.
And then in that session, we have looked at also you need to look at the gap analysis for EECC, that is essential emergency and critical care, which
Donc, les soins, nous avons analysé les gaps,
leverage or seek
les soins essentiels
to find
critiques
what a
et
patient
d'urgence.
needs across all facilities, regardless of the facility, whether you're in high resource or low resource, and then this tends to give you a guide. So you look at the reality, what do you have here and what is the best practice? So you try to identify
Voyons en premier ce qui constitue les meilleures pratiques, sans considérer les limites, les difficultés, le manque de ressources que nous avons. Et puis, la réalité, nous le comparons les meilleures pratiques à la réalité, et puis nous identifions les gaps.
Normal volemia and administer fluids and probably blood and then heart surgery. Now, but in the management of that patient in the emergency,
Dans la gestion de ce patient,
for example, and then
vous
you
avez
don't
par exemple besoin d'oxygénothérapie.
devices. So you look at all these things
Vous n'avez
that
pas
have to
de dispositif pour l'oxygénothérapie.
practice that you need for your center. So you try to identify the gaps. And if it is human resource that you don't have, you try to identify
Les ressources humaines qui manquent.
that you need in the emergency, the minimum requirement that you need. So you identify that and try to address that. So that's how you can achieve the best practice. And then, of course, you identify your goals. When you identify
Vous identifiez vos buts. Qu'est-ce que vous pouvez
what you identified, and then you see what you can address, and then you now be able to
Qu'est-ce que vous
identify
pouvez changer? Qu'est-ce que vous pouvez améliorer?
what are the
Quels vos moyens?
achievable goals for your center.
Donc, vous devez vous fixer des objectifs qui sont atteignables.
And then, how do you manage sedation and choose
Comment est-ce que vous
medication
gérez la sédation et le choix des médicaments pour les patients qui ont besoin d'une sédation prolongée de plus de 7 jours?
Happens in well-resourced settings where you have
Cela arrive typiquement dans
or
les
intensive
hôpitaux. Les ressources sont disponibles.
to tolerate mechanical ventilation, where you have to give invasive oxygen therapy. Now, there are many things which you need to, the patient will require sedation and also pain relief. So
Il y aura sédation, mais il y aura aussi gestion de la douleur.
centers, you know that you have sedation, the levels of sedation, and then you need to have the right drugs to achieve the level of
Vous devez
sedation.
avoir les meilleurs médicaments pour le faire.
Requirement, you don't want a patient is awake, but you don't want the patient to lose the airway, so you try to keep the patient at a certain level. For example, if you employ the Ramsay sedation, the patient within maybe between levels 2 and 3. But below 3,
Regardez le patient à 2 à 3 du score de Ramsey.
So you need to rely on, you need to have the resources, you need to have the drugs.
Vous devez avoir les ressources, les médicaments
To be able to manage a patient for
capable
long
de
sedation.
gérer un patient qui a des médicaments au long cours.
You have these
Et
available.
ces ressources sont disponibles.
The global need
sont
for essential
disponibles
emergency and critical care, essential emergency
pour
and critical
mieux
care,
vous informer autour
score
de
for sepsis,
ces questions dans
and
les
then
soins intensifs, dans les soins essentiels
national early warning score too. You can
d'urgence.
use these to
critique.
develop protocols in your center.
Vous
And
pouvez
many
utiliser
more,
toutes ces ressources-là pour développer des protocoles dans votre centre.
scroll down.
Elles sont toutes gratuites.
To go now, there are also questions that are related to, specifically to COVID-19.
Il y a des questions en rapport avec la COVID-19.
Dr. Salim,
Dr. Salim,
kindly take us through this part.
pour nous aider gentiment à naviguer.
Thank you. We have a frequently asked question. How are
Nous avons des
severely
questions fréquemment posées.
COVID-19 patients?
Comment est-ce qu'un patient hypoxémique atteint de COVID-19 est traité?
Below that, we have the key points that
Nous avons
all
les
providers caring for patients with
Tous
COVID-19
les soignants qui prennent soin des patients COVID-19 ou
personal protective
qui
equipment
sont suspectés
for both, contact, droplet, and
doivent
airborne.
porter des équipements de protection individuelle
It's important to note that
pour se
COVID-19
protéger lors du contact
asymptomatic,
des gouttelettes de
moderate,
flux.
severe, and then the critical illness. So
Donc,
treatments,
la COVID-19 est définie selon plusieurs catégories, asymptomatique, modéré, sévère, critique.
know that for
Les
the
traitements
severe,
varient en fonction de la sévérité des ressources disponibles.
and this is in addition to other
Vous
supportive
pourrez avoir besoin d'oxygénothérapie pour un patient ayant une
oxygen
COVID,
therapy is needed for the severe cases, and in
notamment
some
ceux qui ont des cas sévères.
ventilate the patient.
Et dans certains cas, vous avez même besoin de ventilation.
Improve our oxygenation. Okay, let's scroll down. Okay, another frequently asked question is
Une
how
autre
many
question
liters
fréquemment
of
posée,
oxygen are needed for COVID?
combien de litres d'oxygène
There are no set
les
limits
patients ayant
for the
COVID-19
amount of
ont besoin?
oxygen,
Il n'y a
COVID-19
pas un
patients
chiffre,
Oxygen flows should be titrated to the type of delivery device, and the device
en fonction de
should be based upon the patient's
l'appareil de fourniture d'oxygène disponible
by SpO2 monitoring. Like I said
et
earlier,
déterminé par le monitoring de la SPO2.
set a goal. That's the SpO2 that we want to achieve. So we need,
En
for
fonction de
example,
la cible de SPO2 que nous voulons atteindre,
we don't want the patient to go below 92%. Then that goal should be maintained and should be our guide to titrate or up or down the oxygen therapy. So for non-invasive oxygen delivery device, that's the nasal prongs, the simple marks, the
donc pour
reservoir
les appareils, pour les dispositifs non invasifs d'oxygénothérapie,
oxygen flow
le
is 50
maximum
liters per minute.
est de 15 litres par minute.
When a high flow nasal cannula device is
Donc,
available, the flows can
avec
be as
des
high as 40
dispositifs,
to 60 liters per minute. If
avec des dispositifs
higher levels of
avec un flux élevé, on peut aller jusqu'à 40-60 litres par minute.
positive pressure ventilation or intubation with mechanical ventilation, which can require flows up to 100 liters or more. So we have can we okay, then the next question is how is oxygen administered using a Venturi face mask? What is the role of this device in the
Comment est-ce que
management
l'oxygénothérapie est utilisée pour
COVID-19 patients? Okay.
les masques faciaux
Venturi mask
et quel est le rôle
facial
de cet appareil dans la gestion de COVID?
FiO2 to be delivered to the patient. That's specific fraction of inspired oxygen. to be delivered to the patient. So if available, there are good alternative oxygen delivery devices, but
Donc,
we
disponibles, ce
should
sont
follow
de
that they are
bonnes
not
alternatives
superior or inferior to
à
other oxygen
l'oxygénothérapie.
delivery devices, but rather
Les masques facial Venturi.
available. Okay, so let's scroll down.
Donc, vous les voyez sur l'écran.
One interesting thing about the Venturi devices, they are color coded based
Donc,
on the
C'est
specific
des
FiO2
masques avec
delivered.
des codes couleurs en fonction de l'oxygène, du flux qui est délivré.
Okay. Okay. So the various colors, we have the blue,
Donc, les différentes couleurs, le bleu, le blanc, le jaune, le rouge et le vert.
specific FiO2 that it delivers. So
Et chacun
the
a un FiO2 spécifique qu'il délivre.
24%.
Donc,
Ah,
le bleu, c'est 24% à 2 à 3 litres par minute.
Then the next one is the white, which deliver
blanc
28%.
délivre
Then
20% à 4-6 litres par minute. Le jaune,
which is
35%.
which
Le
delivers
vert, qui est le maximum, qui délivre 60%
60% FiO2.
de FiO2.
And at the flow rate of 12 to 15 liters
À
per
12
minute.
à 15 litres par minute
Almost equivalent to the use of
d'oxygène.
the flow rate used for non-rebreather bag. Although the FO2 IO2 is higher with the non-rebreather bag, because with the non-rebreather bag you can achieve FiO2 of 60,
Avec le masque sans
95%,
respiration,
whereas with the Venturi it can only deliver 60% FiO2.
avec le Venturi, vous avez à 60%, mais avec le non-rebreathable, sans expiration, vous pouvez aller plus.
I think that is it for the Venturi devices.
Donc, c'est tout pour le Venturi.
Then,
Hello,
okay.
hello. No, I just before you move on, I want to just add
Alright.
something on the Venturi.
Je voulais ajouter quelque
If
chose
you,
par rapport-
yes,
Oui.
stay there. If you remember, in one of the questions and the video, high flow and low flow oxygen therapy, you see that we've been told that it's better to stay between 24% and 60% devices that will give you 24% to 60%.
Nous
When you
avions
try
dit
to
qu'il fallait rester entre 4% et 60%
yeah,
pour la FiO2. Parce que plus vous passez à la toxicité, à l'hyper,
centers and participants, whenever they can, to hold on to the Venturi device, because it gives you, we don't have to change the face mask, but you just change the device, which apart
donc
from the
avec le Venturi, vous n'avez pas besoin de changer le masque facial, mais juste la canule, la couleur de la canule.
Now from blue up to the green,
Du bleu au vert,
you will have virtually all the common simple device. You have nasal prongs up to the
vous avez toutes sortes de dispositifs
of
que vous
non-rebreather,
pouvez
that's
utiliser, des
60%.
canules nasales jusqu'au masque facial sans respiration.
So on, then this more or less represent the other three devices here. If you look at the percentage and the flow. Thank you.
Thank you. Okay. The next frequently asked question is how is CPAP or BiPAP used in the management of COVID-19?
Comment est-ce que le CPAP ou le BiPAP sont utilisés pour la gestion de COVID-19?
The key points are
Les points clés, le meilleur traitement pour l'hypoxémie est le flux approprié d'oxygénothérapie sans tenir compte du dispositif utilisé.
Or BiPAP can be considered, but is
Donc, l'usage du CPAP ou du BiPAP peut être considéré, mais c'est très controversé.
risks
devait
to both
être
patients
considéré
and partners with
très
So for
judicieusement pour chaque patient,
appropriate
vu
indications
qu'il y a des
for
risques
use of
que
half-life
les
are
patients,
that for a patient that
les
has
risques pour le
increased
patient et pour le prestataire de soins.
increasing partial pressure of carbon dioxide, that is, patient has problems of oxygenation and then ventilation, despite a maximal oxygen therapy. That is, when, for example, depending on the device that you have, if you have a high flow nasal cannula, you have reached the maximum, and yet the patient still is having respiratory distress, then or an intubation is either not available. So you don't have facilities for intubation, but you have the non-invasive invasive ventilation machine. So, or not within the goals of care, or not advised by the clinician caring for the patient. So, but there are similar indications as in non-COVID-19 patients, like obstructive sleep apnea, or patients with tracheomalacia. All these patients will benefit from the non-invasive positive pressure ventilation. Or patients on home nocturnal CPAP or BiPAP should continue nocturnal non-invasive positive pressure ventilation. And it can also be used on patients with pulmonary edema or patients with exacerbation of
Un œdème pulmonaire.
irreversible hypercapnia. But however, in the contraindication for use of non-invasive
Pendant les
positive pressure
contre-indications,
in COVID-19 patients is generally avoided in the same situation that NIPV is avoided in COVID-19 negative patients. It is severe ARDS without short-term reversibility, and the rest, or when there is altered mental status, because you need a patient that is awake, that can control his airway. So where there is risk of aspiration or risk of aspiration or secretion, then such a patient is not a candidate for non-invasive ventilation. Okay, so let's scroll down. Okay, so there is a video that will
nous avons une vidéo
that will guide us through the use of
qui
non-invasive positive pressure
nous
ventilation.
pour
So let's
l'utilisation des dispositifs non invasifs d'oxygénothérapie.
Welcome, and thank you for watching this important video discussing the evidence on non-invasive ventilation and COVID-19. My name is Dr. Emmanuel Ayavale. I am a clinical instructor and fellow in global health anesthesiology, University of Washington in Seattle, and a technical advisor on the USAID supported UCSF STAR COVID-19 Technical Advisory Group. We will start off by defining the important
Nous allons
terminology.
commencer par définir les thèmes principaux,
Then delve
CPAP,
into the
PIPAP,
specifics of each modality, discussing the current evidence for and against their application in treating patients
et
with
des
COPD.
évidences autour de leur utilisation ou pas.
In addition to high flow nasocannula and mechanical ventilators,
En plus de la
conventional
ventilation
positive airway pressure or CPAP,
plus élevée,
non-invasive positive pressure ventilation or NIPPV, describe oxygen delivery devices or ventilator modes capable of delivering both pressure and supplemental oxygen to patients at high flow rates. High flow nasocannula delivers very small amounts of pressure, whereas
les
NIPPV
canules à fort flot délivrent une, une pression d'oxygène basse.
Non-invasive oxygen delivery devices can deliver high concentrations of oxygen.
Donc, les dispositifs non invasifs d'oxygénothérapie, de ventilation, délivrent une oxygénothérapie à flux élevé.
Non-invasive ventilation or NIV are sometimes used interchangeably.
Donc, ces thèmes CPAP, BIPAP sont utilisés de façon interchangeable, parfois de façon abusive.
Atmospheric pressure to the proximal airway. The result is splinting open the upper airway, increasing lung volume, and increasing intrathoracic pressure. With CPAP, there is no inspiratory muscle unloading. In fact, Tidal ventilation remains completely dependent on the respiratory muscles. The terms NIV and NIPPV can be used interchangeably.
Donc, les thèmes
NIPPV
NIV, ventilation non invasive et ventilation non invasive à pression
positive airway pressure or
positive
BiPAP applies
peuvent
to
être utilisés de
pressure in the
façon
respiratory phase that is greater than the pressure
interchangeable.
during exhalation. NIPPV thus unloads the respiratory muscles and can provide complete respiratory support. Though most modern mechanical ventilators provide both NIPPV and CPAP,
Donc,
there are
ces
also
appareils connaissent
specifically to deliver either NIPPV
tous
or
le NIPPV,
There
la
are
ventilation non
special
invasive
differences in
à
the
pression
performance of
positive
these devices
et
depending
la
on how
CPAP.
well they compensate for large leaks around the delivery interface and how well they respond to patient triggering. There are many home CPAP and BiPAP devices that are unable to treat patients with severe acute respiratory failure, either because they do not accept high pressure oxygen, lack appropriate alarms, or do not have easily adjustable settings. Their suitability for treating less severe forms of COVID-19 remains undetermined. However, there are some devices that are designed exclusively for NIPPV and can therefore accept a high pressure oxygen input. There are multiple ways to deliver CPAP and NIPPV. The oral nasal mask is usually the most common initial interface
Le masque
in terms of leak
nasal,
and patient comfort.
naso-oral et nasopharyngien le
Mask
plus
requires a
utilisé.
tight seal to avoid a leak. Leaks may
Donc,
contribute to
nous avons
patient
besoin
safety
de,
and healthcare worker risk. The seal is important to maintain a constant
nous
pressure
avons besoin
even
de
if the
dispositifs
security
pour
system fails.
bien faire adhérer
It can
le masque
tolerate
au visage pour éviter les
wearing
pertes.
these masks over several days, and frequent breaks and
Le masque ne peut
replenishment
pas
are
être toléré sur le
necessary
patient,
to
surtout
avoid
lorsqu'il doit
systemic
l'utiliser
damage
pendant
and
plusieurs
to
jours.
promote patient adherence. CPAP or NIPPV can be delivered by a specialized helmet, which is more tolerable but
CPAP et
requires higher oxygen flow
NIPPV
rates.
peuvent être délivrés par
These setups are not readily available.
un masque, un casque approprié.
CPAP is a flow-dependent, low-cost CPAP system commonly used to treat
Il y
cardiogenic
a
pulmonary edema.
le CPAP Boussiac qui est
Provide a fraction of inspired oxygen of greater than 50%
moins cher
and is prone to significant leak and patient discomfort, thus limiting its use in
et
treating
qui est susceptible de générer beaucoup de pertes
Early interest in CPAP during
d'oxygène
the COVID-19 pandemic
et
arose for
d'inconfort chez le
several
patient,
reasons.
ce qui rend difficile son utilisation.
There were early suggestions that COVID-19 respiratory illness may have a different physiologic profile than typical severe acute respiratory distress syndrome or ARDS and could potentially respond to CPAP better. Further data has yet to fully support this theory. Second, in some settings which experienced surges of patients with severe COVID-19 and a shortage of mechanical ventilators, non-invasive machines like CPAP were used, with initial non-randomized and often largely anecdotal reports giving hope. Robust data on outcomes to support the widespread use of CPAP in treating patients with severe COVID-19 remain lacking as of September 2020. Third, early reports of intubated patients with severe COVID-19 suggested mortality was very high, spurring desire to defer intubation as much as possible. However, subsequent data has shown that mortality in intubated patients with severe COVID-19 is likely similar to that of non-COVID-19 ARDS and possibly even better. The highest reported mortality rates are likely attributable to overstressed healthcare systems rather than an inherent characteristic of COVID-19 respiratory failure being more lethal than other types of ARDS. There are, however, some evidence-based uses for CPAP and NIPPV that have demonstrable benefit in treating certain conditions, including chronic obstructive pulmonary disease and heart failure. Data for NIPPV and CPAP in many other conditions continues to evolve, often with mixed results from trials such as those studying the potential benefit of CPAP and NIPPV in treating immunocompromised and obese patients, as well as preventing re-intubation in patients weaned off mechanical ventilation. Physiological studies have shown that the helmet
L'étude physiologique montre que les,
face masks.
les casques CPAP
Decreased air leaks may allow for more effective delivery of higher levels of positive end expiratory pressure, or PEEP, potentially increasing
ont des
alveolar
bénéfices potentiels avec moins d'aérosolisation, un meilleur confort du patient, mais avec des problèmes potentiels comme des bruits, des réinspirations, des difficultés de la température, de la chaleur. Et donc, il requiert des flux d'oxygène élevés.
Several studies have shown an increased
Beaucoup d'études.
likelihood of
Okay.
intubation
Thank you. I
mechanical
don't think we don't have
ventilation
much time to
higher
continue
mortality.
with the
Nous
video.
n'avons pas
NIT
assez de temps pour continuer cette vidéo.
used as the initial treatment.
Nous n'avons pas assez de temps pour continuer de suivre cette vidéo.
Okay. Another frequently asked question is, what are the adverse effects of positive pressure?
Une question fréquemment posée, quels sont les effets secondaires de la pression positive chez les patients COVID-19?
Dr. Salim, we cannot hear you. I think Dr. Salim has some internet problems.
A side and a B side. The A side shows ventilation at low long volumes and then ventilation at high long volumes. Ventilation at low long volumes will cause atellect trauma, that is trauma to the alveoli. The B side will cause air leaks caused by overdistension.
Pulmonaire bas,
The
qui
diagram
entraîne l'atélectroma et la ventilation à haut volume, à haut volume pulmonaire.
Bronchial epithelium.
Nous verrons ici les conséquences structurelles, œdème pulmonaire,
Movement of substances that are even not
augmentation de la perméabilité alvéolo-capillaire.
increase in the multiplication of the fibroblasts.
Donc, fibroblasts avec une fibroprolifération.
Mesenchymal transformation. Now, if you go down, we see yes, and physiological abnormalities.
Altérations biologiques.
These are listed, biological alterations. You can see them listed. You can see the physiological abnormalities.
Des anomalies physiologiques.
And then lower down, we see the systemic effects, which
et les
are
effets plus
of lipopolysaccharides, bacteria, and
translocation de lipopolysaccharides,
this can cause
de
multiple organ
bactéries,
dysfunction and even death.
de médiateurs
Dr. Salim, are you back?
Yes, I'm back. Okay, thank you, Dr. Hassan. All right. Okay. So time is not on our side, so we have to go faster. So let's scroll down. Okay. The next question is how
La
does
question qui suit, c'est comment est-ce que les urgences essentielles,
any recent
les soins
updates
critiques et
resources which will be available
urgences
for us
sont en rapport avec la réponse à la COVID-19?
when a patient has symptomatic COVID-19, the patient's
Qui
airway,
a
breathing or circulation may become
COVID-19 de façon
compromised.
symptomatique,
And
ces
early
voies aériennes
identification
de respiration peuvent devenir compromis
here can be life-saving.
et
So this
un
what entails
soin
about the essential
opportun, adéquat, peut
emergency
être
and critical
essentiel.
care.
Voilà
So
là
simple equipment
le
like
rapport entre les deux.
consumables, the drugs, and then the staffing are routines for early identification and timely critical care is often missing. So, and guidelines may be too specialized or not context appropriate. So without these critical care measures, the effectiveness of scaling up oxygen will be very limited. So this is what entails about it, essential emergency and critical care. It's early identification and then instituting the appropriate treatment. Okay, so can we go down? So the resources are available.
Les ressources sont disponibles et vous pouvez les exploiter.
Okay, so the next section is on obstetrics.
La prochaine question a un rapport avec l'obstétrique.
Can you take us through this? Dr. Hassan?
Sorry, yeah. Can we go down, please? I forgot to unmute myself. Yes, so it's going to be a bit fast. This question says, how does the approach for oxygen and critical care differ
pour l'oxygénothérapie et
from our previous sessions?
fait
We have understood that pregnant women are different. They have different physiologies. They have changes in their physiological
les femmes enceintes ont une physiologie différente.
And so the approach is going to be a bit different from the normal pregnant women and other individuals. We know that there are changes in the respiratory system with increase in oxygen demand because of the
changements dans la respiration avec une augmentation de la consommation d'oxygène. Changement au niveau cardiovasculaire.
Different with even the positioning and even when it comes to prone positioning and CPR and the rest, we have different approaches to the pregnant woman. The second question says, is there any benefit to the fetus when you administer oxygen to a woman?
Est-ce qu'il y a des bénéfices pour le fœtus lorsque non administre l'oxygène à une femme en travail?
When you give oxygen to the
la
mother,
connexion, c'est le placenta.
From the mother through the placenta.
Donc,
so that
lorsque
is why
vous
when
donnez de l'oxygène à la mère, l'enfant en bénéficie à travers le placenta.
So we have key points below. Okay, it says oxygen should be given to pregnant women with hypoxia. So it is there are no exception. When there is hypoxia, if the woman is pregnant, she also gets oxygen. In fact, it should be more than the other ones. Maternal blood supplies the placenta and the fetus.
L'oxygène devrait être donné à une femme enceinte ayant une hypoxémie. Mais la fourniture du sang maternel à travers le placenta.
WFSA and others recommend a target.
Le sang maternel fourni à travers le placenta et le fœtus devrait être normalement oxygéné, avoir un niveau normal de saturation.
Different targets.
Donc, nous avons différentes sociétés avec différentes.
Question says, are there
et la SPO2 doit être à plus de 80%, par exemple, dans la société pour les Society for Maternal Fetal Medicine.
And we have the resources here. They are variable resources.
Donc, des ressources qui sont disponibles pour les soins COVID-19 aux femmes enceintes que vous voyez là.
Okay, now we go to pediatrics. Dr. Datti.
Passons à la pédiatrie maintenant.
Yes, thank you. I'm back. I had a network glitch, so I had to change the my device. So I think we are running short of time. Let's scroll down and see the question, at least one question on pediatrics. How is oxygen therapy provided for infants?
Comment est-ce
and
que l'oxygénothérapie est fournie aux enfants?
The first
Et
question we know we
est-ce qu'il y a-
have to rely on
La première question, nous
the
avons
nasal catheter for infants, and then you also
Euh,
have the nasal pumps for children. Yes, you can
prendre en
administer
compte les nasales,
children. And then there are protocols.
les canules nasales pour les enfants. Vous avez des ressources là que vous pouvez utiliser.
Yes,
Vous
scroll
voyez
down.
également qu'il y a des protocoles COVID-19 pour les enfants.
So, in summary, we have tried to address
En résumé,
some of those
nous avons
questions.
essayé de répondre à certaines des questions qui ont été posées. Toutes les questions sont importantes, mais
COVID-19
nous avons dû en choisir
But you
quelques-unes.
see, the common denominator there is oxygen therapy here.
Et le dénominateur commun à toutes ces questions, c'est l'oxygénothérapie.
Present in such a manner that you can apply most of this and change your practice wherever you are, no matter the setting.
Et nous les avons identifiés et utilisés dans vos ressources. L'éducation, c'est l'outil le plus puissant que vous pouvez utiliser pour changer le monde.
Whatever we were able to gain through the last 11 sessions plus this one to be able to change our practice wherever we are. I want to thank
Je voudrais remercier sincèrement
the co-panelists that
mes
have been with
copanélistes
us throughout.
qui
Salim,
ont été avec
Ibrahim,
nous,
Hassan, Alimena,
Salim, Ibrahim, Hassan,
Irene,
Irène,
who was unavoidably absent today, Henry Embu, and Suleiman. And I want to thank us
Ambo.
International and ECHO for giving us this opportunity to contribute to knowledge. Thank you. Kevin, over to you.
Merci.
Thank you so much, Dr. Datti, and thank you to the panelists as well. So as we mentioned before, this was the last session for this year, and I would like to remind them that you can access the materials and resources that you have through the Learning Resource Center.
Accéder
We usually
tous les matériels de travail.
in our WhatsApp group, whereby you can register and have access to all these
Lien
materials.
vers nos matériels,
So
les
with
ressources
that, I would like
disponibles dans notre groupe WhatsApp.
close today's session.
Nous sommes à la fin de la session.
My screen.
Je voudrais partager mon écran.
So just a reminder, as I mentioned, to visit the Learning Resource Center. And for those of you who have not joined our WhatsApp group, you can scan this QR code that is seen in the screen, and then you can have access to our WhatsApp group, whereby we share
Scannez le code pour accéder à notre groupe WhatsApp.
and you can also send a message to assist through that number.
Également, envoyer un
Thank you
message.
so much for joining, and for those of who
Remercions de
have been with us since the beginning of this series, we thank you so much.
Merci.
And we will see again each other next year if God wishes. We wish you
l'année prochaine.
blessed December, Merry Christmas, and Happy New Year 2022. Thank you so
Bonne
much.
Et bonne année 2022. Merci.
For India team, I think we can close the session.
Nous pouvons fermer la session. Merci.
Manjeet, we can close the session. Thank you.
I think